and then moving on to the next part of this session, which is a panel. And I want to introduce our three esteemed panelists. We have Malia Boggs, who is a Senior Technical Advisor in Child Health at USAID. And we have Audrey Battu, who is Director of Essential Medicines in CHAI, the Clinical Health Access Initiative, otherwise known as CHAI. And we have Dr. Alison Morgan, who is a Senior Health Specialist in MNCH at the GFF, the Global Financing Facility. And Alison, if I may perhaps start with you, actually, given the recent and very, very welcome change of language in the Reclaim the Gains campaign, which the GFF is kind of launching and driving from ORS alone to ORS and zinc, with an incredible ambition of adding, I think it's nearly 500 million children onto ORS treatment through ORS and zinc over the next 4 years. So I'd love if you could maybe say a few things about this, and of course use the opportunity as well to reflect on the three excellent presentations we've had so far. So over to you, Alison.
Thanks very much, Sami, and it's a real pleasure to be part of this launch today as someone who began their medical career in the mid-1980s working in a rural Bangladesh hospital in a diarrhea centre and a paediatric clinic. It's really exciting to be part of this ORS Zinc COPAC Alliance launch today. Congratulations to all the members of the Alliance, and again, particularly to Simon and Leith for providing through all the members the evidence and creating the momentum to ensure that children receive quality care for diarrhea. I was really struck by these last three presentations about the compelling evidence for its effectiveness. And I think it is true that, you know, in the last 40 years, we've learned so much about optimal treatment of diarrhea, but still much to be learned about the how to ensure that all children receive both ORS and zinc. I was struck by the principles outlined in a review published by ORSZCA and colleagues in Toronto last year on the implementation barriers and opportunities, namely availability and accessibility, awareness and education, partnership engagement strategies, and adaptive design to enhance acceptability. And I think there's a huge role in the COPAC Alliance for the adaptive design and the generating the evidence. And I think there's also a role for agencies like GFF, USAID, and other major players on ensuring that availability and accessibility. So as Sami has alluded to, the work of the Global Financing Facility is to support governments to address the health system bottlenecks to accelerate progress in reproductive, maternal, neonatal, child, adolescent health and nutrition outcomes. More specifically, I think our focus in these next 4 years is really on ensuring that the gains achieved by many countries are not reversed as a result of the pandemic. We know that in the first 18 months of the pandemic, more lives were lost as a result of health service disruption than from COVID. And so the GFF, you know, in this slogan of reclaim the gains, is working to better monitor real-time stock out and service coverage, support for governments to provide innovative responses to ensure essential health services are maintained, and convening through country platforms the engagement of development partners, CSOs, the private sector. And I think that co-packaging actually is a great solution to some of these supply chain challenges as well. It might be one of those global health teachable moments to accelerate progress in the midst of a pandemic by seeing it as addressing, you know, many of these implementation challenges. And as Sami has alluded to, in Zambia, a country I'm a little bit more involved with within the GFF more recently, you know, co-packaged ORS and zinc through the work of Simon and colleagues, it's really institutionalized through those processes, getting it on their essential medicines list as a co-packaged product, developing it locally, manufacturing it locally, getting the distribution right. And it is the first go-to product now that all health workers use when a child presents with diarrhea. So we know this is doable, and I want to hand over now to Malia for her reflections from USAID. Thanks.
Yeah, thank you so much, Alison, and thank you to the co-chairs and to the organizers for inviting me to be part of this global launch of the COPAC Alliance. I really commend this group for standing up to advocate for a renewed focus on ORS and zinc as part of strengthened diarrhea case management in order to save hundreds of thousands of children's lives, as we've heard. This is an especially critical time for an alliance like this, given that the pool of children at risk of dying from preventable diseases is growing during the COVID-19 pandemic, and given waning global momentum to improve coverage of timely and appropriate diarrhea case management. This waning momentum on the need to focus on child's health and diarrhea specifically is an important driver of the insufficient progress that we've just heard about from Dr. Black. So in terms of, the role of, agencies and organizations like USAID in supporting further reductions in illness and death from diarrhea, the unfinished child survival agenda is a very high priority for USAID. Based on the last 18 years of work to scale up the availability and use of ORS and zinc, we know what works. We need to build on the lessons from countries with high coverage, such as Bangladesh, and take action to catalyze greater progress to reach the most vulnerable children, especially in the countries or in the regions of a country that are falling behind and where diarrhea is a leading cause of under 5 mortality. 54 countries are off track to meet the SDG under 5 mortality target by 2030. So we need to focus on off-track countries where the burden of diarrhea is highest to support these countries in meeting their SDG commitment to end preventable deaths. We also need to focus on countries that are on track, but where there are pockets of poverty and poor coverage. And so while we know that increasing access to high quality, low osmolarity ORS and zinc is essential, we also know that prevention and protection that we've also heard about from Dr. Black through optimal nutrition, vaccination, and water sanitation and hygiene are also critical components of a comprehensive approach to reduce diarrheal incidence and accelerate reductions in child mortality. At USAID, we are proud of our investments in routine immunization and our close partnership with an annual contribution of $290 million annually to Gavi, the Vaccine Alliance, in part to scale up rotavirus vaccination in dozens of countries. With that, I want to hand over to you, Audrey.
Thank you so much, Malia. I'm really excited to be talking about zinc and ORS today. Chai started working in the pediatric diarrhea space 10 years ago in 2012. And I think we've seen a lot of progress in the countries that we have been working in. And so in India, Uganda, Nigeria, and Kenya, and then most recently Ethiopia. But I think what's really exciting is our experience at Chai is really similar to the experience of what our speakers shared and what Alison and Malia have reinforced. We know that this is possible, right? Coordinated, comprehensive approaches in partnership with governments, private companies, and civil society really is what dramatically increases zinc and ORS use. And it sustains or even continues to increase it when those things are working together. And I think that was clear from what everyone said so far. The other piece I would add is that we know that there are specific interventions that are needed to address policy issues. A good example is at the start, zinc wasn't available in many countries over the counter, and so that needed to change. But also addressing market bottlenecks, making sure that the cost was affordable for zinc and ORS, and then provider practices, making sure, as Dr. Black shared, that the appropriate products were being prescribed. And then finally, from India, we kind of have that example of consumer demand, right? So making sure that caregivers know about the products. And I think India has been a really successful example of doing that. So I think we know that this is going to vary by country context, but all of these areas are really critical to address simultaneously. And I think really exciting to see the role of the co-pack in increasing coverage. And as Malia said, just a renewed focus on this. Malia, maybe I'll pass back to you. You know, as we kind of build on these decades of work, including in countries like Bangladesh and India, how do we do that? You know, what do you think is needed? And feel free to bring in our speakers too.
Yes, thank you, Audrey. We've heard a lot already about some of the history, and I also just wanted to share, some of the work that USAID has done over the last 60 years. So as many of you know, USAID has supported research and program implementation in low and middle income countries to accelerate these reductions in under 5 mortality, especially from preventable causes like diarrhea and pneumonia. What we heard about in terms of the history in Bangladesh, USAID supported actually some of the original research in Bangladesh in the 1960s to develop the first formulation of ORS in collaboration with WHO and other research organizations. During the 80s, USAID funded pilot programs to promote the use of ORS. And then during the following decades, we also supported additional research on the efficacy, safety, acceptability, and effectiveness of zinc treatment and low osmolarity ORS. And this research actually informed the 2004 WHO and UNICEF joint statement on the management of acute diarrhea. And, as we've heard already, we've learned a lot about introducing and bringing ORS and zinc to scale after the release of the joint statement. We initially forged partnerships with international and local pharmaceutical companies to address gaps in supply and to ensure that high quality zinc products were available for international and national procurement. And like, what Dr. Ahmed mentioned about Susie, we also supported global and bilateral programs in both the public and the private sectors to strengthen the prevention and management of diarrhea. And these efforts really resulted in significant improvements in national policies, treatment coverage, and care-seeking behavior in many countries in Africa and Asia. We also joined together with other donors, NGOs, and partners at the global level through groups such as the Zinc Task Force, the Diarrhea and Pneumonia Working Group, and the UN Commission on Life-Saving Commodities for Women and Children to address global and country barriers to access. And so today, while policies are in place, and as we've heard, zinc and ORS are much more widely available now than they were in 2004, we really see that limited funding and poor quality of care provided to children with diarrhea prevent sufficient coverage and effectiveness of the intervention. So we know, for example, based on an analysis of service provision assessment surveys conducted in 7 countries, that the majority of public and private sector providers in these 7 countries don't assess and treat diarrhea correctly in accordance with IMCI guidelines. So we need to continue to improve the quality of care for diarrhea at all levels of the health system, and also advocate with governments about the need to continue to focus on diarrhea as part of the unfinished agenda. We also, recognize this esteemed panel has, decades and decades of experience, and really wanted to also bring them in and pose the question, to you all about what programmatic challenges, you've encountered in India and Bangladesh, and how have, your programs really overcome them. So, Dr. Ahmed and Dr. Singh, I don't know if you want to respond to this in terms of how have you addressed, the challenges to scale up over the many decades that you've been implementing programs?
Dr. Singh, do you want to go first?
No, sir, you can go ahead. Yeah, please.
Okay. I think one of the major, let me talk about, scaling up zinc. And before that, I think you have very nicely highlighted the problems and how USAID came forward to help with the initial, experimentation and then the scale-up activities regarding ORS. Those were very critical days when the community at large, and in particular the medical community, just simply refused to accept. They said that, well, when we have this IV fluids, we don't think that this oral fluid thing can work, So that was really very frustrating. Even when I started my career, even during those days in the 80s, I could see there's a lot of resistance, but gradually this was overcome. How was it overcome? First of all, we had to have small demonstration projects. Many of us, we will not agree now that the utility of such demonstration projects would not be great. But I think in retrospect, such small demonstration projects that really helped improve the acceptability among the leaders. And I am talking about the leaders in the medical profession, the leaders in the civil society. So they did this project and then they found that, yes, it really works. And then they started spreading the message. So that was, I think, about ORS. And then gradually people, when this was aggressively being promoted all over the country, people, they realized that, yes, when you have a child in front of you who is having, moderate to severe dehydration, and then you give sips and sips of ORS, gradually, little by little, the child, recovers. So that was really very, very important for them. Regarding zinc, I again mentioned that Susie was eye-opener. So this was a project to ICDDRP, and there were two goals. One is to bring in zinc. At that time, we didn't have zinc. So we had to somehow produce the zinc within the country. And for that, you can imagine, we had to purchase the license from another company and then give this license to a local pharmaceutical company. And then ask them that, okay, from now on, how about pressing this, dispersible tablets, okay? So that was the first thing. The second important thing was convincing and converting those who did not believe that zinc was good. So then came in the evidence, and I would say that, most of the very influential evidence came from Dr. Black's work that he did in Bangladesh, along with that of Dr. Baki, and also Dr. Roy. So these were the evidence that we found it very, very helpful when we went on to promote zinc. And then finally, the communication, I think that was one of the best things. There was a television commercial called Baby Zinc. And even I, who knew everything, whenever I heard this Baby Zinc television jingle, I used to stop and listen. This was so enchanting, captivating. And that was done by a very famous, television personality. And I think a lot, goes to that. So these are the things that I think are very important for scaling up in any typical country like Bangladesh.
Yeah, thank you so much, Dr. Ahmed. I mean, I think that we started off with a lot of small demonstration projects and also trying to address the lack of supply of zinc,
Right.
everywhere. And I remember that technology transfer from Nutriset to Acme and some of the issues, but thank you so much.
Right.
As well as the Baby Zinc, mass media jingle and commercials. So it was really a fantastic program. Okay, and I know we're running short on time, but I do want to hear from Dr. Singh. So Dr. Singh, over to you, please.
Yeah, thank you so much. I think, echoing with Dr. Ahmed on this, I would like to share some practical examples, actually. How does the community takes on all this process of absorbing zinc into them? So what we have observed in the field is that, when we give 40 tablets to them, so the households, they very often find it very difficult to manage them, to store them, and to feed them to their child. So one of the challenges that we very often face that, why don't you give us syrup for that? Now, the challenge with the government is that if they procure syrup instead of tablet, the cost increases many-fold times, actually. So first, second, when they will go to some private sector, they will mainly find syrup composition of zinc to be given to them. So taste-wise, everything-wise, they seems to be very good to them, so they prefer to that one. But speaking to that, how we can do, I think one of the very important aspect that is needed is that can we run a campaign, dedicated campaign on use of zinc, as you were talking right now of baby zinc campaign as altogether? How a government leadership can be brought into it, and zinc can be a kind of medicine or product that is readily available at all the places. As I mentioned in India, that there are certain legal compliances to be made actually for zinc to be readily available across all the private platforms. For example, if today I want to keep zinc at a shop, grocery shop, I cannot do it actually, because legally, as per our act, you need a permission, you need a license to do that kind of thing. Another very important aspect that I want to highlight, we also did a kind of a study in our project to understand the people's understanding. So people very often find it very difficult to bifurcate the doses even actually. For example, how much of zinc should be given to a child of 2 years child or 6 months child. So that challenge is also. Plus, if we can have innovative product packaging in place, child friendly, so that may enhance the use of GKs within the community itself. Yeah, I rest myself here.
Thank you, Dr. Singh, and for those amazing examples of the really focused, nuanced challenges that happen in every context that we all need to be across. I think we have to finish up our panel time. I just want to thank the speakers again. I think from the GFF perspective, in terms of the sort of what's next and the call, you know, our work generally works with governments to develop an investment case and to look at the system changes. Sometimes that means that we're looking at, you know, financing reforms or supply reforms rather than looking at intervention-specific programmatic work. And so you know, this has been really great to listen to all of the examples from the different countries and the work that's been done. And I think going forward, what my takeaways are that the evidence is there, but we still need to remind people of that. We can't assume that that's a known, that in the work that we're trying to do around really creating the decision space at the peripheral facilities to really do, you know, adapt systems to ensure treatment is happening even in the face of pandemic pressures or others, that there is, you know, parallel implementation research and a real agenda to try and understand all of those small barriers and limitations that can prevent what is clearly evidence-based in terms of the co-packaging being delivered at scale in all of the countries that we work with. So I'll stop there and hand over to you, Malia.
Thank you. And just building upon the others, and including what I think Dr. Ahmed already has mentioned, you know, thinking about what needs to happen differently in the countdown to 2030, you know, I want to reiterate that we need, you know, political will, focused action, and targeted resources to better prevent and manage childhood diarrhea. We really can't maintain a business as usual approach to avert, you know, the deaths of over 400,000 children every year. I also want to mention data, that collecting, you know, high quality data is essential to accurately monitor programs and assess progress. And better use of data, for instance, through national and subnational dashboards or scorecards is really needed to improve targeting of our investments in programs, and especially to address the needs of the most vulnerable and marginalized. You know, we do have, as I mentioned, and we've heard, we have decades of program implementation experience. And so we know that comprehensive programs should include policy, supply, and demand. So, you know, this really entails supporting government leadership, ensuring the quality of ORS and zinc in both the public and the private sectors, generating caregiver demands, and strengthening provider practices. And so while we know that, you know, programs need to be adapted to the local context, all of these components are really essential. Again, the supportive policy environment, the quality, the mass media coupled with interpersonal communication to create demand, and building the knowledge and skills of providers. So I would just close by saying that concerted action is still needed to strengthen health systems and the care children receive at home, in communities, and in facilities, to ensure that the use of low osmolarity ORS, zinc, and continued feeding and fluids are the standard of care for every child with diarrhea. With that, over to you, Audrey.
Yeah, thank you, Malia and Alison. Really great discussion and great bringing in our other speakers to respond. Sammy, we're going to pass it back to you. I think this leads into kind of the next step of how do we do this and the work plan that I know you'll be talking through. But I think we all agree this is possible. There's a lot of work to be done. It needs sustained investment. But I think the takeaway from all of us right now is that this is really doable.
Absolutely, and brilliant to end on such a positive note. Thank you very much to our three panelists, Alison, Malia, and Audrey, for your reflections, for bringing in the speakers, and also for kind of bringing in all the institutional knowledge and the history of the three organizations that you represent, which are very important players in the diarrhea control landscape globally. So thank you very much for that. We will have a time for Q&A, by the way. It will be 15 to 20 minutes, and we have been kind of pasting the questions from the chat box in a spreadsheet, which I'll be looking at and going through later on. Before I do that, I do want to spend the next 10 minutes talking about our proposed work plan for ORSZCA, the Global Alliance for ORS and Zinc co-packs. I don't know, Sita, if you're able to share the slides, or would you like me to do that?
Either way, I'm happy to share the slides if you prefer.
If that's okay, that'd be fantastic. Thank you so much.